us. We were really pleasantly surprised by the turnout today, especially because it's the last week of August. It's also the last week of National Immunization Awareness Month for those of you who work in the vaccine space and care about the vaccine space. So go Awareness Month. And my name is Sue Peschin, and I serve as President and CEO of the Alliance for Aging Research. We're going to be taping today's webinar, so it can be like cats. You can see it again and again. We'll be sending out emails to all of you with hashtags and links after the webinar, but if you want to do any type of social media during the webinar, we welcome it. Our hashtags, we have a couple, so you have your choice. Hashtag Wellness Wisdom, Our Best Shot, Dose of Truth, or for the Awareness Month, NIAM 2019. If you want to ask a question or make a comment, there's a feature in your right-hand panel, and it has Q&A on it, so please just type up your question. And we can answer questions when it makes sense throughout the webinar, but we're also going to have a Q&A at the very end. So for those of you who might not be familiar with our organization, the Alliance for Aging Research was founded in 1986, so we've been around for a little over 30 years. We're a national nonprofit, and we're located in Washington, D.C., and our mission is to promote research to improve the experience of aging and health. And promotion of prevention through vaccination is an important part of our mission that we've been working on for a number of years. And our website is agingresearch.org. Now, we started in the vaccination issue back in 2015. We thought it would be interesting to look at sort of patterns of behavior and what influences vaccination behavior among older adults by looking at federal survey data. So we partnered up with Bates White Economic Consulting Firm, and we looked at rates and trends and health insurance coverage policies to sort of figure out what types of questions have been asked on federal surveys and whether or not education correlates with utilization. And in this case, compared to a lot of other public health issues, education does highly correlate with utilization. So unlike diet and exercise, where we've all heard a lot about that, but tends not to influence our behavior too much, with vaccination, there's a huge opportunity. And the more you know about it, the more likely you are to get them. So because of those results, and as striking as they were, we decided to launch an education campaign with some materials that could be used at the local level. And so our Best Shot education campaign was born, and we partnered up with area agencies on aging and a lot of the senior centers that are underneath their umbrella. We created some of the materials were translated into Spanish, and all of the materials are available on our website. If you do our website address at the bottom of the page there, /vaccination, you can download them all for free. We encourage you to use them. These were developed a couple of years ago, and they include a pocket film that's about 5 minutes long, as well as a PSA campaign that has been used on television and also for digital use. Those can also be downloaded and used on iPads, on smartphones, wherever you think it's most useful for your audiences. So please use our materials. In 2017, a couple years later, we started to see some anti-vaccine sentiment in sort of the general public and a lot of social media. And we thought that older adults would serve as a great sort of army of truth tellers, because a lot of older adults remember in the 50s and the 60s, back when polio was around and the polio vaccine came on, and how the nation just, sort of rallied around the necessity for having vaccines and the importance of them. In addition, research shows that as we get older, we tend to cultivate altruism more in our life. And so the idea of grandparents helping their grandkids helping to educate their kids to make sure their grandkids are vaccinated and their kids get vaccinated. And also this concept of herd immunity, to make sure that a certain amount of folks get immunized within the community to really create protection within the community. In addition to that, we know that a lot of older adults talk to their friends, and so they can be influential not only in their own families, but in their communities at large. So this Truth Tellers fact sheet was created, and again, this is available for download. You can individually use some of the infographics. We know those are popular today, and you can kind of isolate and highlight the ones that are useful to you. It's available for everybody. And this fact sheet really debunks a lot of the common misconceptions on both adult and child vaccinations. So we encourage you to use this. And it was added on to our community leader kit. So it's also on that page as well, and you can use it as a part of about a 1-hour program if you wanted to do an education program within your community center. Now, despite the work of groups like ours and certainly all of the infectious disease groups, both focused on kids as well as adults and other senior organizations, adult vaccination rates are still lower than what they need to be, both for herd immunity and then for overall public health goals, according to Healthy People 2020. Dr. Schaffner is going to talk a bit more about the recommended vaccines by age group, but we just wanted to show you that there's still a real significant need here, so there's opportunity. And when we thought about it from our perspective as an aging organization, we thought about what are the opportunities within the Medicare program. And a lot of you are probably familiar with the Medicare Annual Wellness Visit, which is a preventive visit that was created as a part of the Affordable Care Act back in 2010, or Obamacare, as it's, I think, more commonly known. And the idea behind the annual wellness visit at the time was that Medicare was seen as an acute care program. In other words, you went to see your doctor when you had a problem. And there was a recognized gap in the idea that with older adults, there was a lot that could be done in prevention. So the annual wellness visit was created. And this is different from the initial preventive exam, or the Welcome to Medicare exam as it's known, which is a one-time benefit, and that's something that you do in the first year of being on Medicare. This is an annual benefit, and there's no cost sharing associated with it, so there's no copayment or coinsurance associated with it, and folks are eligible to get it every year. And it's the only recurrent benefit within Medicare that includes discussion of all the Advisory Committee on Immunization Practices recommended vaccines. There's also a lot of other screenings that are discussed as a part of it, and some health risk assessment is taken. And we thought this was a great opportunity because there's just under 60 million folks on Medicare in the United States. 51.2 million of those are age 65 and older, and 8.8 million are people with disabilities. So we just thought that this was a great opportunity. And in fact, there was a journal article in the journal Vaccine that came out in 2017 that did take a look at some claims data and showed that folks who got the annual wellness visit were more likely to get their recommended vaccines. Now, you could sort of argue that folks who are likely to get the annual wellness visit are more likely to care about their health in general and would be more likely to get vaccines. But they did show this relationship, and we thought that's an important relationship and something that's important to take a look at. Estimates vary, but the overall average is that about 18.8% of eligible beneficiaries get the annual wellness visit, so there is a lot of room for growth here. It has grown over time. When it first started back in 2011, the uptake was around 8%, so it's gone up over 10% in this period of time, but there's still a lot more room for growth, and that's why we think vaccines is a good entry point for a lot of our organizations that are interested in this issue to promote the exam. In addition, the uptake really varies depending on whether you're in a Medicare Advantage plan or in fee-for-service Medicare in terms of the emphasis on these preventive services. So we developed this resource back in 2018 to expand our Best Shot Workshop Kit that highlights the preventive visits, both the Welcome to Medicare exam and then also the annual wellness visit. The Welcome to Medicare exam also includes a mention of history of vaccines and opportunity to discuss vaccines, but again, the annual wellness visit is the recurring benefit. And so this Wellness Wisdom Fact Sheet, also available for free download, is aimed at beneficiaries, and it includes information not just on the exams themselves, but also coverage and payment issues, and the differences between Part B Medicare and Part D for the drug benefit and where vaccines fit into that. So it's a useful resource in that regard. But once we created this, it made us think about how is this piece being implemented as part of the visit itself, because when you look at claims data, as that 2017 vaccine study did, it really only tells you whether the entire visit occurred or didn't occur. It doesn't give you any information on how different pieces of that visit are implemented. So we were interested in digging in a little bit more, which is why we decided to do this survey and get down to the nuts and bolts of what are folks hesitant about, both on the provider side as well as on the beneficiary side, what information they feel like they have and don't have, and then how follow-up is done. If they need a vaccine, does it happen on that day? Does it happen later on in a different place? And our full slide deck on the survey is available on our home webpage, again, at agingresearch.org. And you can we also have a subpage, agingresearch.org/vaccines. We created kind of a cool infographic, if I can editorialize on my colleagues' work, that goes through the survey results that you can also feel free to download and that you can use to follow along as we go through the survey. And I do want to thank our VP of Health Education and Advocacy, Lindsay Clark, for the great work on this. Also want to thank our funders, GlaxoSmithKline, Merck, Pfizer, and Securus for their support of this work. We would not have been able to do it without you. So now I want to introduce our survey researcher who's going to walk us through what we found. Andrew Rugg serves as president of Certus Insights, and he was also the lead survey researcher on behalf of the MSL group. So welcome, Andrew, and thanks for being here.
Great. Thanks so much, Sue. It was really a pleasure to put together this survey. So I'm going to walk you through some of the high-level insights that we found in the survey, as well as review some of the findings. So wanted to move down here to the methodology page and review kind of overall what we tried to do. We conducted two methodologies when it comes to the project. We conducted some qualitative interviews in March and April amongst primary care physicians and nurse practitioners who see Medicare beneficiaries and conduct the annual wellness visits. We then followed that up and we used those interviews to help create a quantitative survey questionnaire that we fielded in June, again to primary care physicians and nurse practitioners who see Medicare beneficiaries and conduct annual wellness visits. Both the interviews and the survey were conducted using online, panel, the interviews were conducted via phone and the survey conducted online. What I'm going to review today is some top-level findings that we found. There's a lot of material that we looked through and found in the survey. But here on page 6, one of the questions that we asked in the survey was of primary care physicians and nurse practitioners to rank their priorities during the annual wellness visit. And what we found is that there were 3 tiers of priorities. We asked them to rank each topic, 1 through 10. So, and then the scores that you see here on this page are averaged. The lower the score, the higher the priority. And so there were 3 clusters of priorities. Under the tier 1, current ailments, general health, and current medication history. Then on the second tier there, past medical history, blood pressure, cholesterol, family history. And then on the lower tier, there was past medication history, chronic diseases, then vaccines, then mental acuity. So as you can see, vaccines are placed in the lower tier in terms of their priority of discussion during the annual wellness visit. Only 2% of respondents said that vaccines are a top priority during the annual wellness visit. We also asked about what fears, misconceptions, and barriers that nurse practitioners and primary care physicians experience and prevent Medicare patients from getting the recommended vaccines. We asked, if the fears, misconceptions, and barriers occur frequently, occasionally, hardly ever, or never. So if we just look at those top 2 responses, the frequently and occasionally, the top barriers include fear of adverse reactions at 74%, fear of vaccine side effects like pain at 69%, belief that the vaccines cause the disease they are supposed to prevent at 68%, and costs of vaccines at 67%, and belief that vaccines are harmful at 65%. So those kind of clustered together as top barriers. There was also some significant barriers that didn't quite rise to the top, but still had large response levels. Conflating one vaccine with another at 61%, health visit co-pay cost 60%, vaccine availability at 59%, and the cost or time to seek out a pharmacy to administer the vaccine at 58%. We also asked what vaccines primary care physicians and nurse practitioners include in their screening schedule for Medicare patients during the annual wellness visit. Of all the survey respondents, 70% say they include influenza, 63% include pneumococcal, 63% tetanus, diphtheria, and acellular pertussis, 60% zoster, 44% hepatitis A, and 40% include hepatitis B in their screening schedule. What we found in the interviews with physicians and nurse practitioners was that patients are more open to receiving the zoster and shingles vaccine, in part because they knew or are aware of others who have suffered from shingles and they know how bad it is. Excuse me. So in general, they're more receptive to that. Conversely, the in-depth interviews also found that there was some pushback on the influenza vaccine, mostly due to how frequently it's administered, which was interesting to find. We also asked in the interviews about a variety of other vaccines: measles, mumps, rubella, varicella vaccine, meningococcal, and then a variety of other vaccines, and we found that they aren't typically discussed during the annual wellness visit, mostly just because they're not the Medicare population isn't the target population for those types of vaccines. Moving on, we also asked about whether primary care physicians and nurse practitioners typically prescribe standard dose, high dose, or adjuvanted dose vaccines to their populations. We found that both the IDIs and the survey research respondents will recommend the high dose if respondents are of a certain age, have a chronic disease, or there's other risk factors. And then particularly what came out during the interviews that we conducted is in the absence of recommendations from the CDC, there's some concern about the default administration of high-dose flu vaccine to the Medicare population. But when we asked in the survey, what respondents typically prescribe, and this was a multi-select question, meaning that respondents could give multiple responses, 56% of primary care practitioners and nurse practitioners, they report prescribing the standard dose. 40% said they prescribed the high dose. Moving on, we also asked about the vaccination requirement within the offices that respondents work at. And we found that 78% say that their office does require all healthcare workers to receive the annual influenza vaccine. 19% said they did not. 4% said that they don't know. We asked a series of questions in the survey about information that nurse practitioners and primary care physicians offer patients to mitigate barriers or fears that they might have to getting vaccines, and also ask them what information they feel they needed to better educate parents. And there was a variety of interesting responses here. When it comes to the information that they typically offer to patients, 58% said they explain the risks of not getting vaccinated, 54% say they explain the benefits of vaccines, and 53% say they explain standard vaccines and the diseases they prevent. In other words, vaccines kind of 101. When we asked them what materials they needed to better educate patients, 40% say they want more information on the risks of not getting vaccinated, 39% want information on the vaccines that are covered and not covered by Medicare, 33% want information about the standard vaccines and the diseases they prevent, 32% want the number of people that get severe side effects as a statistical proof point, 32% want information on the benefits of vaccines, 31% want facts that come back, common myths and misconceptions, and 23% want locations of appropriate pharmacies. And what we found here in these questions, as well as in the interview, is that it seems that there's a more common prevalence to discuss and want information about risks instead of benefits. So stick instead of carrot, if you were, when it comes to talking to patients about vaccines and getting around any misconceptions or barriers they might have. This is particularly interesting and it's kind of worth noting. We made sure to include in both the qualitative interviews, but in the survey, a mix of nurse practitioners and primary care physicians that worked in a clinical and a hospital setting. We noted that there are some really important differences and sometimes substantial between vaccination behaviors and Medicare Annual Wellness Visits conducted in the clinical setting and compared to the hospital setting. And in the clinical setting, there's greater use of Medicare Annual Wellness Visit checklists, greater use of prompts from the EMR systems. Vaccinations are more commonly included in the screening schedule. It is more likely that all vaccines are offered. More respondents take the patient's word for vaccination compliance. More respondents typically prescribe standard dose flu vaccines. More respondents are very familiar with the National Vaccine Advisory Committee standards for adult immunization practice recommendations. And more respondents report needing information on the number of people that get severe side effects. And all this suggests to us that there may be a need to differentiate how communications occur between primary care physicians and nurse practitioners in the clinical versus the hospital setting. There's several other findings that we had in the survey, but those are the top level takeaways, so I'll kind of stop and pause there. I guess I'll take questions later or now or whatever is most convenient. But it was really a privilege to work on the survey. We all hope you find the results as interesting as we did. There's just a lot of very interesting perspectives from these primary care physicians and nurse practitioners on the issue of vaccines and Medicare Annual Wellness Visit. Thanks.
Thank you, Andrew. That was great. Okay, I think we're going to do questions towards the end rather than right now, just to make sure that we, get through all the talks, and then we'll have some time for discussion. So our next speaker is Dr. William Schaffner, and he serves as Medical Director of the National Foundation for Infectious Diseases. He's also Professor of Preventive Medicine in the Department of Health Policy and Professor of Medicine in the Division of Infectious Diseases at the Vanderbilt University School of Medicine. Dr. Schaffner, thanks so much for being with us.
Well, hi, Sue, and I'm so glad to be with you today. And thank you for the Alliance for Aging Research's interest in immunizing adults, particularly older adults, And thank you, Andrew, for an exceedingly, I think, insightful set of results that have come from your survey. I think they really inform what we would like to do. It is working. Each year, the CDC's Advisory Committee on Immunization Practices produces an adult immunization schedule. They do the same thing for infants, children, and adolescents, but they produce one for adults. It's not reproduced here, but this comes from that schedule. It's published annually, usually sometime in January, and it lists all the vaccines by age category, which ones adults are eligible for. And it has a second table which also indicates all the vaccines and indicates which, if you have underlying illnesses, if you have certain behavioral characteristics, if you're in certain occupations, once again, which vaccines you ought to get. If we reduce all that to what it is we ought to focus on for people age 65 and older, it really becomes quite simple, because the major vaccines we're concerned about are, first of all, influenza vaccine, second, tetanus, diphtheria, acellular pertussis, Tdap vaccine, zoster, and then the pneumococcal vaccines. That will occupy 93.7% of your concern regarding adult immunizations. It's true that patients who have diabetes should be considered for hepatitis B vaccine. So that's another one you might want to put down on your list. So focus on these major events. On occasion, there may be somebody age 65 and older who's eligible for another vaccine, particularly if they are international travelers, but that's a separate discussion. So it's clear that older adults need vaccines. We're all susceptible to a variety of diseases. And as this infographic shows you, it's particularly important because as we get older, our immune systems, just like the rest of our bodies, become less robust. They're less strong. And so they need the assistance of immunizations to protect us against a variety of infections. This influenza example shows that whilst using standard influenza vaccine is a good thing, it might even be better to use one of the two vaccines that are specifically licensed for people age 65 and older, the high-dose vaccine, which contains 4 times as much antigen as the standard dose. It has, as I like to say, more punch. And then there's also an adjuvanted influenza vaccine. It contains an adjuvant in addition to the flu vaccine. The adjuvant is an immune stimulant. And there are data to support that both these vaccines, and incidentally also recombinant vaccine, produce superior immune responses in people who are age 65 and older. And there are also data, particularly for the high-dose vaccines, to show that they protect about 25% better against influenza. While we're talking about influenza vaccine, it's well to acknowledge that flu vaccine is not a perfect vaccine. We all know that. Some years it works better than others. Let me make an important point that I think is not sufficiently appreciated. We measure influenza vaccine effectiveness the way we do other vaccines, quite appropriately so. How well does the vaccine prevent the disease completely? And those are the data we hear, which vary from year to year. What's underappreciated is that no matter how well the vaccine prevents the disease completely, if you're vaccinated and you get flu anyway, and this is the important point, if you get flu anyway, you're much less likely to have a severe infection. In other words, your infection is likely to be milder. You get partial protection. It won't last quite as long, probably a day less. And you're less likely to develop the complications of pneumonia. You're less likely to have to go to the hospital and be admitted, especially to the intensive care unit. And you're much less likely to die of influenza. That's all good stuff, which is underappreciated. Not entirely facetiously, when I occasionally had a patient whom I vaccinated, but nonetheless got flu and came back the next visit and was grumpy about that, I said, "I'm so glad you're still here to complain." And I made the point that his illness undoubtedly had been made milder by his influenza vaccine. So the benefits of flu vaccine, I think, are underappreciated, and we still have many, many people whom we ought to vaccinate. Now, Andrew provided some nice information about barriers, and here they are represented in this graph. I find it fascinating that there's a fear of adverse reactions. Now, obviously, vaccines, if you get an injection in the arm, when I get my flu shot, I have a sore arm for a few hours. And I'm not sure exactly how people age 65 and older consider this. Is this a really big deal? Or is it just that they don't have enough information and haven't been sufficiently reassured? I think it's also fascinating, look at that green bar, that vaccines cause the disease that they're supposed to prevent. Talk about a paradoxical notion. I think that comes from that old myth, and it's a myth, that you can get flu from the flu vaccine. That myth, I'm afraid, is still out there. Of course, that probably originates from the fact that we start vaccinating in the fall, and people can get respiratory illnesses in the fall. If they get their vaccine on Monday and they start with the sniffles on Wednesday, they may falsely think that the vaccine caused the sniffles, caused the cold. Of course it didn't. Those were just coincidences. Now, another barrier, and this is a real one even for the Medicare population, is the cost of the vaccines. The Medicare program is absolutely wonderful, but it's not perfectly wonderful. As you know, undoubtedly, under Part B, as in boy, there is first dollar coverage for influenza vaccine and the pneumococcal vaccines and the hepatitis B vaccines. So people just have to roll up their sleeves, they get their inoculation, they don't have to reach for their wallets, the vaccine is paid for, and the healthcare provider gets an administration fee. Wonderful, no barrier. But some vaccines, unfortunately, through the wisdom of our elected representatives, have been allocated to Part D of Medicare. Part D is the prescription drug benefit, originally set up in order to help people pay for their medications at the pharmacy. But Tdap, tetanus, diphtheria, acellular pertussis vaccine, is allocated to Part D, as is the shingles vaccine, Shingrix. So although the CDC, the Advisory Committee on Immunization Practices, recommends that every person age 65 and older receive those two vaccines, they are in Part D. Not every Medicare recipient elects Part D, And under Part D, although all the plans must cover the vaccines, some do have copays, some do have deductibles, and some, I understand, you have to lay out the money and then submit the bill to the insurance company, which will reimburse you, I don't know, 3 months later. So those encumbrances are barriers. So the cost of the vaccines, even to the Medicare population, for some of the vaccines, important ones, Tdap and shingles vaccine in particular, are a barrier and something that the provider and the patient will have to discuss. So what sort of information can you give to patients to mitigate all of these barriers? Before we get to the information, let me say, because there are now oodles of studies that show this, the single most important determination of whether an individual, an adult, becomes vaccinated is the recommendation for the vaccine by the provider. The recommendation for the vaccine. Now, you're going to be surprised because I'm going to tell you not to recommend the vaccine. I'm going to tell you to insist on it. I want providers to be vaccine insisters. Why do I say this? So here's a little scenario. It's the fall of the year. Patient Tom is with the doctor, and the doctor at the end of the visit, this usually happens at the end of the visit, says to Tom as Tom is leaving the examination room, "Tom, it's this time of the year again. You ought to consider getting your flu vaccine." Now, the doctor thinks that that's a recommendation. I think that's giving the permission to the patient to say no. What you've got to do is be a vaccine insister and say, "Tom, it's that time of the year. You'll get your flu vaccine on the way out." That already will guarantee that 60% or more of the patients will get their vaccine. Now, if the patient stops and says, "Doc, I'm not so sure about that," then stop. Focus on the patient, look a little bit surprised, and say, "Tom, you seem to have a caution. Tell me, why are you concerned about getting the flu vaccine?" First of all, you've empowered the patient. Tom will then tell you, "Well, I don't think that vaccine really works, Doc." Then mirror back to the patient. "Ah, Tom, you're concerned about how effective the vaccine is. I hear you." Validating to the patient that you have heard them. And then you go on to your insistence. Every doctor, every healthcare provider will have their own style. I put my arm around the patient and I say, "Tom, let me tell you, it's not a perfect vaccine, but it's the best that we have. I'm vaccinated. My wife is vaccinated. Look around. Everybody in this office is vaccinated, and our goal is to provide this best protection we can provide to every one of our patients. We want 100% of our patients to be vaccinated. So come on, Tom, roll up that sleeve. You'll get your flu shot as you leave." I promise you, variations on that theme, vaccine insistence, your vaccination rates will rise to 90+%. Not perfect, but you'll get to 90%. Some patients will want more information about specific aspects of the vaccine. Of course, once again, listen, mirror back, and then take the time to provide that information to the patient. But if we attend to how it is we present vaccines to our patients, we will get much, much higher acceptance rates. As one of my colleagues likes to remind us all, we don't suggest to patients that their diabetes or hypertension is treated. We tell them how it will be treated. Why do we do it differently with vaccines? Don't recommend vaccines. Insist on them. And apropos of that, it's barely enough time because we have only these limited amounts of time in the visit. You've got to kind of plan it in advance and make it a priority for yourself. One of the interesting things about Andrew's data was that as I saw it, and this is kind of a quick interpretation of your good data, Andrew, I think doctors and patients treat the wellness visit kind of like it's a normal sickness-related visit. Because obviously they review current ailments, think about their general health, get into their medical history and their medication, their current medication history. That sounds like a regular visit. It doesn't sound as though it were a visit with different goals emphasizing preventive health care. I think we need more education of providers as well as patients about the goals of the wellness visit. I've mentioned this a little bit before, having to do with which vaccines are actually covered under Medicare Part A versus Part D. That's something that's, at least my crystal ball tells me, is not going to change in the near time future, so we're just going to have to deal with this coverage limitation and just work on it and do the very best we can to provide the most vaccines to most of our patients. And to emphasize, the annual wellness visit is an opportunity to emphasize preventive health services. And of course, we have this annual opportunity, which we haven't exploited optimally. Let's work on all of that together and see if we can't get more emphasis on prevention into these visits. All of us working together, messaging together to educate providers and patients about this opportunity and the benefits that vaccines can bring. If we all sing in harmony, then the music, I think, will work. I've stretched that analogy a little bit there, haven't I? There are a number of additional, in addition to all of the information that the Alliance for Aging Research has provided, the National Foundation for Infectious Diseases has also provided a whole bunch of tools, information materials, infographics, and the like. They're all available. Please take advantage of them and use them to the benefit of our patients. Thank you very much.
Thank you, Dr. Schaffner. That was excellent, so helpful. I want to encourage folks, if you haven't asked a question or made a comment yet, to use the right-hand panel to type in your question. We have about a half a dozen questions, but just wanted to let folks know that you still have that as an option, and we have a little bit of time here. I also wanted to let everybody know we are going to be sending a follow-up email, and we'll include all the links to the NFID resources, along with a link to the recording of the webinar and the hashtags and everything that you could possibly need. So let's get going on some of these questions. And the first question I want to direct to Dr. Schaffner as a clinician. I'm sort of wondering from your perspective, what do you think are sort of maybe the top 2 or 3 things that CMS and the Medicare program can do to create sort of messaging materials for providers? You saw the one bit that we had up there through their MLN Matters program, but what else do you think providers maybe need to better integrate vaccine discussions into the annual wellness visit and anything on specific vaccines?
Well, you know, in preparation, Sue, for this webinar, we went back and looked very briefly at some of the materials they already have. And there's a handbook for providers regarding Medicare. And deep in that handbook, pages 46 to 48 or something like that, there's a discussion of the wellness visit. I think the wellness visit simply isn't well known. And so they need information about that. I found it absolutely fascinating from Andrew's information that both providers and patients, about 40% of both, need information about which vaccines are covered under Medicare. Well, gee, that's a pretty fundamental concept if we're going to effectively deliver vaccines. And if 40% of providers are a little confused about that, don't have enough information, I think CMS really needs to get that out there in an easily accessible fashion.
I would agree. And we're going to actually send some contact information for CMS for some of the groups that are interested in directly contacting them. They have a group that regularly reviews their educational materials, and the Alliance for Aging Research participates in that. But I think it would be great for other groups and groups that are, specifically interested in vaccination to participate and encourage CMS. We've done a little bit of that, but it helps to have, an echo chamber going. So I think that's great. Dr. Schaffner, another question for you. One of our participants here said they heard that the PCV13 is no longer recommended for seniors, which I guess is pneumococcal. Is that true?
I'm laughing. I wish you hadn't asked because it's a little bit complicated. So give me a moment. I'll give you a short paragraph. The ACIP 4 years ago recommended that everyone reaching age 65 who had not been previously vaccinated with pneumococcal vaccine should receive both of the pneumococcal vaccines. First, PCV13, that's the conjugate vaccine, and a year later, they should receive the polysaccharide vaccine. Very simple recommendation, everybody age 65 and older. Now, they have just recently reevaluated it, and the reason for that is that PCV13 used in children has been so successful, it's actually also eliminated the carriage back in the nasopharynx of those PCV13 pneumococcal strains in kids. And it turns out that kids are the great transmitters of those strains to their, for example, grandparents, to adults. Well, if you eliminate carriage in kids, then you don't give those strains to adults, particularly older adults, and so they also don't get sick with those strains. So this was a huge indirect effect, and the effect was so great that the ACIP said, we don't have to make this recommendation a standard recommendation for everyone age 65 and older. So the current recommendation is as follows. It's still a little complicated. If you are immunocompromised or you have a series of recommendations for pneumococcal vaccine, such as smoking, or you're asplenic, just to choose a couple, or if you're immunocompromised, then you should still get both vaccines. If you are an otherwise healthy person, age 65 and older, you should engage in a discussion with your provider and, under shared clinical decision-making, come to a decision about whether just one vaccine is sufficient, that would be polysaccharide vaccine, or whether you choose the belt and suspenders approach and get both. So you have a permissive recommendation for healthy people to get either one or both, but for immunocompromised people and others with high-risk indications, they still should get both. I hope that's helpful.
It is. It is definitely helpful. Okay, the next question has to do with the high dose versus the standard dose flu vaccine, and I think actually both of you, Andrew and Dr. Schaffner, might have something to say on this one. This also sort of raised my eyebrows, the finding about concern about a default administration. In the in-depth interviews, there was concern by healthcare providers about using the high-dose flu vaccine to the Medicare population as a default in the absence of recommendations from the CDC. Andrew, I was wondering if you teased that out a little bit more, if you found out like what the concerns were, if it was just because there wasn't a direct recommendation, or if they felt like maybe it was just limited to folks who had certain diseases that were more vulnerable. And then Dr. Schaffner, I think it would be interesting to hear from you on why, there isn't more of a direct recommendation around this for older adults.
Yeah, it's a really interesting question, and it was a really interesting topic that we explored in some of the interviews and came through in the survey as well. But the concern was, and it seems that a lot of the primary care physicians and nurse practitioners that we discussed to, it seems like they like to discuss with the patients, and identify potential reasons why they would administer a high-dose flu vaccine, whether it's because there's some other condition that they have, or there's some other risk factor that they're incorporating into the recommendation. So it seems like they want to cause and not make it the default, otherwise give them the standard dose, or at least have a discussion with the patient about it. So the concern seemed to be that there wouldn't be a discussion, that the Medicare patient would walk up to the pharmacy without even really knowing it. They would be being administered the high-dose flu vaccine. That seemed to be the cause. And, a lot of the respondents, they paid a lot of attention to the CDC recommendations on the issue, on the matter. And commonly some of the materials and the handouts that they give in their practices come from the CDC. So the lack of a recommendation kind of gave them pause about what there should be their default position. And it seems like their default position is wanting to at least discuss or have a reason for the high-dose flu vaccine. That being said, some of the physicians and nurse practitioners that we talked to, they did just say, no, we just give the high dose. We give the high dose until we no longer have it, and then we start giving out the standard dose. So there certainly was a mix of responses, but it seemed that the primary response was, wanting to have a discussion with the patient about it.
Yeah, so let me follow up, and I'll give you a brief look at the perspective from the Advisory Committee on Immunization Practices. We start out with the notion that the ACIP is very reluctant to give preferential recommendations. They do on occasion, but they're not so keen on it. The last time they looked at this question, should high-dose vaccine be administered preferentially to standard dose vaccine for people age 65 and older, was back when there was only high dose vaccine that had been licensed for people age 65 and older. And so they decided not to issue a preferential recommendation, but just to describe the two vaccines. And I will tell you frankly that one of the concerns at that time was, because this was all just beginning, this vaccine, the high-dose vaccine, was just beginning to be supplied, they said, gee, we can't issue a preferential recommendation because we're not sure the company can actually supply the demand. So if high dose is not available, for sure, get standard dose vaccine. Now, time has gone on. We now have an adjuvanted vaccine that's also licensed for people age 65 and older, and there are data from the recombinant vaccine that have been published, although it's not licensed particularly for people age 65 and older. It shows that that vaccine also provides a better immune response than does standard dose vaccine in people age 65 and older. So we're in a new circumstance now, and I can tell you, this is not secret, that the Advisory Committee on Immunization Practices subcommittee, the Influenza Vaccine Work Group, is now just beginning to look at this whole question again of people age 65 and older. Which vaccine ought they get? Ought there be a set of preferential recommendations? No telling what they will decide, and this is a process that will take some time. So we have these vaccines now available for people age 65 and older, and everyone says, use them if you like. The data do show that they work better in people age 65 and older, but by all means, even if those vaccines are not available, for sure, don't let the patient leave unvaccinated. Use the standard vaccine because that's better than nothing.
Okay, that was great. Thank you. We have another question that somebody sent in to us around what types of health promotion materials around vaccination are most effective for reaching those age 65 and older. And I'm going to actually turn this over to my colleague, Lindsay Clark, who is our VP of Health Education and Advocacy.
Well, thank you, Sue. I think the answer is there's no one material that's going to be the best. No, it's not one size fits all here. So we've had a lot of luck with doing a variety of things. And as Sue talked about earlier in the presentation, we have an entire kit that focuses in on that fact. So we have seminars so that if people are looking for information at their senior centers, at their libraries, at other places where they convene, those materials can be offered. If they want something to take home with them or download on their own because they are looking for information or they're in a setting where it can be given to them, something like our vaccine schedule and take-home brochure is great. We do know that as much as a lot of our materials have shifted to videos and electronic, people still, older adults especially, still love a brochure that they can hold and take home with them and reference when they need it, and hopefully share with their friends and family and talk about some of these myths that we discussed earlier. We do know that also that there's a lot of success with films, which is why we create pocket films, and so we have an animated version that Sue referenced. Those are great because they're available when people are looking for information on the internet. They can be used in waiting rooms. They can be played on demand in any healthcare setting. We also have had luck turning them into PSAs, so they run as nonprofit PSAs and reach millions of folks. And they can be, so those obviously can be used in a lot of settings. We also find that, especially in a space like this where we know we're relying a lot on the healthcare professionals to insist on the vaccinations and not just recommend them, and there's a lot of gaps in information, that creating materials that are for the healthcare professionals, recognizing that there are some gaps oftentimes, no matter the space and information. So we come at it from both directions, patients and healthcare professionals. And obviously, NFIT has a lot of fabulous resources that were shared a few slides back. We'll have this available online if you want to reference those, because those are fabulous as well.
And Dr. Schaffner, I want to give the last question to you, and then we're going to wrap up. This one, I think, is a good, compelling question here. This person responded to the survey finding that said almost 1 in 5 healthcare workers said their office doesn't require the flu vaccine. So the question was, should beneficiaries ask whether everybody in the office has been vaccinated as a way to kind of, I guess, encourage? Or also I might want to ask you, like, what do you do to make sure everybody is vaccinated?
So, Sue, that's a wonderful question. And when I saw Andrew's data, I groaned a little bit, because I think certainly those of us who work in the hospital environment, and that's where I work, increasingly hospitals are obliging every healthcare worker in the institution to be vaccinated annually, with rare exceptions. And that's certainly what we do here at Vanderbilt. We don't fire anybody, but we do have vaccination rates that are in the high 90% because it is the norm. Everybody is told who comes to work here that we all get ourselves vaccinated, not only to protect ourselves. My quip is, during a flu outbreak, we want to be vertical, not horizontal, right? We want to be here to help our patients. So we want to be vaccinated, but it's a patient safety issue. We don't want to give flu to any of our patients. And so I would hope that no matter what the healthcare setting you're in, that you as a healthcare provider protect yourself in order to protect yourself and to protect your patients. We should all be vaccinated annually. It's both a professional and an ethical obligation.
I love it. That's great. I think you came up with another hashtag, stay vertical. Yeah? Okay. I just want to thank our funders again for supporting this important work. And last, I want to thank all of you for joining us today. Really appreciate you being here, and please look out for our follow-up email, and have a great rest of your day. Take care, everybody.